Hello. Um, we would like to start with the next session, so please, if you want to continue your conversations outside of the room, if you're not interested in this one, which I can hardly imagine because it is a very interesting session actually. It comes under the title Prosthetics that are high quality, affordable and available. And I have to admit that there is some overlap, not too much, but there is some overlap with the previous session, which actually was talking about locally produced assistive technologies. Can I have my slides? Play my slide, please. Do I need to push? Or? The introductory slide, yes, there we are. My name is Evert-Jan Hogewerf. I am the Secretary General of the Global Alliance of Assistive Technology Organizations, GATO. And I also happen to be involved in the Association for the Advancement of Assistive Technology in Europe. But that global aspect is actually what is most relevant here today, this afternoon. Because actually we have speakers from different places in the world that are trying to develop and promote and sell their products. And of course, for an organization like GATO, we are a platform, a global platform of non-for-profit membership organizations of assistive technology stakeholders. This is a very relevant topic. Our mission as GATO is to contribute to a barrier-free world where everybody has the possibility to enjoy access to assistive technology and rehabilitation technology, to live with dignity, independence, and full participation. Thinking about this session, it came to my mind the importance of having, at national level, good working assistive technology ecosystems. Because having a good product is one point, but having it also embedded in what is the local infrastructure, or maybe also the infrastructure of your country next door to you, is extremely important. So we need to boost, to foster access to assistive technology, good working assistive technology ecosystems at all levels that involve all relevant actors, but not only the actors, also policies, procedures and protocols that actually help the products to be able to reach the end users. There are different stakeholders involved in such an ecosystem, of course, end users, industry, and today we will look to a couple of examples of that, suppliers, distributors, service providers, etc., etc. So also research is needed, so the whole value chain of assistive technology actually comprises all those different stakeholders, and it is important that they're all on board if you want to have progress. There is a global agenda in this regard in fostering access to assistive technology, and you heard a little bit about that in the previous section from AT-Scale, but there are others. The World Health Organization is driving an important agenda around assistive technology. And they are totally in line with that thinking of a system thinking approach. So although today we will discuss with some of the speakers about specific aspects of the opportunities, but also the barriers that they encounter in bringing their products to the market and to the end users, there are really a lot of domains that have to be assessed if we want to foster and create better working AT ecosystems. WHO identifies different domains like people, which is what do we know actually about the needs and about the end users and what are the gaps there. Policy, products, provision, personnel, the training, it was already mentioned in the previous session as well, how important training is. Other authors actually added promotion, or basically, I mean, they wanted to stick to the P and the game with the P's. But basically, we're talking about information. How do you get your information out there? partnerships with whom you work in an ecosystem. Pace, how timely is intervention when it comes to assistive technology? Very often we lose time, and which is precious. Procurement and place, whether you work in an urban area, maybe close to a university or a research center, or whether you work in a rural area, of course that makes a huge difference. So that's what we're going to discuss today, and oops, this is the previous slide because one of the speakers is not here, so maybe it was not updated. Anyway, we have Mohamed Daoufi from Cure Bionics in Tunisia. Welcome, Mohamed. Enzo Romero from Peru.
Yes, sir.
From Lat Bionics. Welcome. And Anna, sorry, Anna, Zastapanek from Penta Medical Recycling in the US. I spoke a lot, too much probably, so I hand over immediately to Mohamed for your for the first presentation.
Hello, everyone. Thank you so much for attending this session. So my name is Mohamed Daoufi. I'm from Tunisia. I'm the CEO and co-founder of Cure Bionics. We are a prosthetic technology company, and I'll be happy to share more information about it in a second. So I'll be starting with a video, actually. Can you
change the slides? It's coming.
Okay. So before the video, okay. So our company is specialized in designing, developing, and manufacturing and fitting prosthetic devices that are CE certified. We do bionic, cosmetic, and passive functional prosthetics for upper limb and lower limb, plus rehab technology. So we spent quite good time in R&D to the full value chain for patients. So here's the video. So it's going to explain the process quickly. So we start by 3D scanning the patient, even with an iPhone. Then with our device, detect the muscle placement sensors. Then with our device, we do 3D simulation thanks to some bracelets and devices. Then the team does the 3D modeling of the socket. Now we are working on automating that. We have a lot of machining. The prosthetic is not fully 3D printed. We have a lot of metal, titanium for resistance, etc. We 3D print the socket. We assemble it. We test it with the hands. So everything is manufactured by us. Then it's tested by a patient. This is controlling with the muscle sensors, with our own socket solutions. We do the same process with the lower limb. So we scan the residual limb of the patient. We 3D model and we 3D print the socket. Then we assemble it with multiple joints, either for above knee or below knee. And then we go to the fitting phase, and we have happy patients. So basically, we have multiple range of products. We do B2C and B2B. For the B2B level, we manufacture multiple prosthetic parts, from bionic hands till like this one, as you can see here. We have also passive terminal devices for specific activities. You can exchange them to do activities like sports, gym, swimming, playing with ball, etc. Like this one for the ball. This is the sockets we are talking about. So we also have our own bionic elbow joints, mechanical elbow joints, our wrist solutions, EMG sensors. We also do sockets. So sockets for above elbow, below elbow. It's our sockets. It's adjustable in size. Let me show you. So basically, patients can still enjoy some space in the socket. So it's never uncomfortable for the patients. We also do rehab. So we have multiple apps on the phone, tablets, or TVs. With the muscle bracelet, patients can enjoy stimulating their muscles while playing some games or doing 3D or 2D hand simulation. We also do knee joints. So we have 4-axis knee joint developed by our company, and 2-leg or 2-foot, sash foot and carbon foot. For the B2C, we found a huge need in our region, especially starting from Tunisia. We wanted to offer the full solution to our patient in a digital way. So we have 2 centers. It's called Cure Care. we do from 3D scanning till the modeling, till printing, till the fitting of the patient, and we are scaling through this model also. So our hands, talking just about the bionic quickly, so it has haptic feedback, so you can feel the touch with vibration. It has a precise grip. You can customize the skin color. There are, under the glove, you can have multiple buttons to change modes. For example, there is the freeze mode. So once it's once it's red, the hand is locked in a certain position, so we can enjoy live without being afraid, opening or closing involuntarily. It has rotative wrist. It has a strong grip, above like 10 kilograms, I guess, more than 10 kilograms. We have an NFC tag allowing for emergency calls, opening a door, etc. So it can be programmed, and it's connected, so you can still calibrate and configure and monitor the bionic hand. I'll talk about another feature later, which is for clinician. For the socket, it's charged with a magnet charger, like a smartwatch, so no need to remove the battery. It's adjustable, as I was explaining, so no size is bad for the patient. No one will come back complaining about the size. The cure care patient journey, so for our centers, this is what happens. So they come to us, or we go to them, or they send us the 3D scan, then we do the automation of the socket design, then we do 3D printing, assembly, and then the patient fitting. This is what we give to patients. So the Hannibal arm is the full bionic arm. The Angel arm is a cosmetic arm. The Flow arm is for passive activities, so we can do a lot of amazing things. We work with Paralympic athletes. We have the Hasdrubal leg, above knee, below knee. And we have the full MyoRehab ecosystem, so multiple devices, tools, and apps that helps the patient to enjoy rehabilitation while playing in, how we call it, in an interactive and immersive way. So what we offer somehow is advantages in multiple areas. So we can deploy autonomous microprosthetic clinics with low budget, in small space, without heavy machines, without too much human factor, so we can scale with low budget. Secondly, we can we offer the full integration and fitting for all amputation levels. So not just the hand, not just the rehab, but the full value chain. So it enables us to be more inclusive for our segment or audience. We also offer socket solutions. So most of the startups doing prosthetics sometimes offer only the terminal devices solutions and rely on other centers. So for us, it was a bit tricky because it can lower the quality sometimes from a center to another. It can make it take too much time, more than expected for the patient, the after sales, et cetera, et cetera. So we still work with centers, but we have our own way of doing things. And this is one of the advantages. Also, the socket itself has very, let's say, advantages, features like the adjustability, the magnet charging feature. We also offer all of this at an affordable cost because we control the value chain, we can play with cost, with margins, and we can be closer to our patients. And finally, we have remote setup and calibration solution. It's called the Myo setup, so the clinician can connect in real time with the patient. They can calibrate the hand without the patient coming to them to change sensitivity, the force sensor, EMG sensor, etc. So we can make a lot of things remotely. So for now, we impacted plus 60 patients. We are working now for Tunisia and Libya and implementing with 3 other countries, Sudan, Saudi Arabia, and Rwanda. We have 2 cure care clinics, and we work with multiple B2B clients, including the Ministry of Defense in Tunisia, the military hospital, and other institutions. So this is one of the cases. His name is Abdallah. It's Abdallah and Muhammad Abdallah, double name. So he got electrified, and he lost both his hands before his wedding. Unfortunately, his first wife left him. That was bad for him. It was very sad story. And then we had a call with him when he was at the clinic. And we told him, he was asking about simple things. Can I drink a coffee again? Can I smoke again? Can I go back to work again? And we said, we'll do that together. So we didn't promise anything, but we assisted him since day 0. And now he's working. He's enjoying a new happy life with his wife. He's enjoying his cigarettes. We don't recommend that for him, but he still do that. He's enjoying his early morning coffee. So we felt a lot of pride making someone's life better. And I guess this is what assistive technology is about. It's not about 100% changing someone's life, but at least making them enjoy life, having equal opportunities, and making them closer to the 100% in the end of the day, because we cannot offer 100% perfect solution for everyone. So we have multiple case scenarios here, like Paralympic athletes, children, adults, accidents people, people with birth defects, and we are still working on making their life better and better. So we are a multidisciplinary young team. So I guess I'm the older one in the team. I'm 33 years old. We are very talented, very motivated. We have regulatory team also. So whatever we develop, we take it to the regulatory level to make it scalable globally. So our challenges, I guess, like every startup, finishing with this, I guess, funding, scaling channels, partners, and suppliers. We can support us with funding, implementation partners, and the global programs and hubs as we are trying to take this impact on a larger scale. And next steps for us is more and more tech, more expansion, and fundraising. This is our ask if someone is connected to investors or grant providers. And yeah, thank you so much. Thank you. I'm more into the entrepreneur mindset.
Thank you. Yeah, I can totally see that, Mohammed. Thank you. And if you raised 2 million today, then I'm happy to receive 10% of scheduling you here. Okay, thank you. Let's keep the questions until the end of the session. So we move forward to Enzo.
Of course.
Hello, good afternoon, everyone. This is Enzo Romero. I come from Lima, Peru. Originally, I was birthed on a beautiful place called Cusco, which is, if have you been to Peru and you have traveled to Machu Picchu, probably you should have passed throughout where I was born. And this is a story of how this entire setup of what we are doing at Lad Bionics began as a dream of myself. So as you may see, I'm a user of assistive device, as most of you here. And this was a dream that I had when I was a kid. So hopefully you get to watch Star Wars, the #5 movie. And in that scene at the end, Luke Skywalker gets lost his hand. But then in the next scene, the medical droids fitted him with a prosthesis that could move and feel like it has this instant sensation. So from then on, no greater purpose lived in my mind, which was to have a prosthesis like Luke Skywalker. So this dream led me to study mechatronics engineering. I have a master's degree in mechatronics too, and also as a co-founder of Lad Bionics, I work as a university professor in Pontifical Catholic University of Peru, where, of course, I discovered, since we were applying for funding and so, I'm not the only person with this condition. As you may know, according to WHO, 4 out of 5 people with upper limb amputation conditions live in developing countries, such like mine. So for example, let's take Peru. In Peru, there are at least 40 new cases reported to the Ministry of Labor of people who have lost their hand because of work-related scenarios. But you must consider that in Peru, we have an 80% rate of informality, which means that only 2 out of those 10 companies do actually report to the Ministry of Labor. So what actually happens is, if you get to lose your hand into a work-related scenario, you're not going to have any insurance at all. And if you want to buy a prosthesis for yourself, a robotic imported prosthesis can jump to cost $25,000. So in order for you to have an idea of how much it is for a person who's living in the minimum life wage, they would need to save at least 7 years, not caring about dressing nor housing at all. So we found this outrageous. And that is why we get to create Lad Bionics. Lad Bionics is an organization where we develop upper limb prosthesis for people of low income who live in Peru and all across Latin America. And we are capable to develop these affordable solutions because we use digital manufacturing technologies. Such as Mohammed, we use a 3D scan to have a digitalization of the amputated area. Then we have our own software where we get to create the entire set of fingers, the palm and the prosthesis socket, which is the most important part of it, to finally manufacture all of those pieces using 3D printing. So far we have 2 types of prosthesis. One are our mechanical body power prosthesis, like the one I am using right now, and also our electronic activated prosthesis, which of course has a battery, EMG sensors, and microcontrollers inside of it, and motors too. But most recently, we found a challenge. So a user of an electronic prosthesis would use a prosthesis like this for many more hours. But much like going to the gym, at the end of several hours, they will start to feel some fatigue, some muscular fatigue. And for those who are working with EMG, this is the worst thing that can happen to you, because now you're having a signal that is not as strong as used to be at the beginning. So our challenge was this. How can we still be working with EMG, but have a next innovation about it? So this is when AI jumps into our formation. The way we will have is we develop our own neural network that requires the signals from the users. So we will proceed to set up the entire set of EMG arrangement all across the closest muscle that is near to the amputated area. Then we will develop our own program in which they will be facing like small gestures so as to train this neural network that we are working with. Accordingly, then the computer will recognize which type of gestures these people are trying to perform. So for example, if it's a flexion, if it's extension, if they're trying to put a rest position, and just with these basically functions, they will operate the prosthesis at the end. So we have created a complete made setup process to not only develop a solution that is personalized and customized for every user accordingly to their EMG signal data, but of course we also develop the prosthesis accordingly to what the weight and the length of the prosthesis may have. So it is a one-to-one person process that we are creating right now. And finally, this, as I told you, has begun as a dream of myself, but it actually belongs to these 2.4 million people who live in countries like mine, who require these sort of solutions. And accordingly to our costs, our AI-driven prosthesis can jump to $2,500, which is 10 times less the cost of an imported robotic prosthesis. So we're betting on the local talent of our population. We're betting on the local talent of our industrial designers, of our biomedical engineers, in order to avoid getting to buy transnational big tech companies who are spending their money in our regions without having in consideration the necessities of our people. And even at this cost, you may say it is affordable. Well, for at least 60% of our applicants come from poverty situations. So we have established installment plans to pay it in 18 months, 24 months. So just after 3 weeks of the 3D scanning, they will have their prosthesis already. And with that prosthesis, it makes them easier to get back to work. So now they can pay us like in advance or probably in the future. We actually have a little rate of churn of people who disappear at all with their prosthesis because now they become part of a community because we do the maintenance, we do the setup of the EMG sensors and so. Please, if you would like to talk more about what we are doing in Peru and our plans to scale across all of the regions, please contact me. Thank you so much for your attention.
Thank you very much, Enzo. It's another amazing story,
Thank you so
actually. It's fantastic. No, let's move on. Otherwise, I'm so full of questions. I bet you're full of questions as well. But we're going to take them towards the end. Anna, your presentation is slightly different, but looking forward to it as well. Please go ahead.
Yes. Can you hear me?
Yes.
Wonderful. Thank you. Thank you, Luke Skywalker. That was amazing. Hello, everyone. I'm going to lead with accessibility and say that my name is Anna Strapanik. I use she, her pronouns. I am a white female in her late 30s with shoulder-length, wavy blonde hair. I'm wearing a blue turtleneck and a tan blazer. I also want to start by saying I'm just so honored to be here today and sharing the stage with incredible change makers, not only here on this panel, but sharing this entire space with all of you, so thank you. And I'm also excited to tell you about what pentamedical recycling does and how we are working to advance mobility and access to prosthetics around the world. To start, Pentamedical Recycling is a nonprofit organization based in the United States, and our mission is to collect excess, surplus, secondhand equipment from around the US and redistribute that extremely valuable, expensive, and useful equipment to low and middle income country clinics all over the world. Why do we do this? We do this because, as we know, there is a tremendous need for this prosthetic equipment all over the world. We know that there's anywhere from 60 to 100 million amputees globally, and 90% of them lack access or availability to needed prosthetic equipment. Meanwhile, in the United States, there is an excess. There's an excess and surplus of this equipment. Each year, hundreds and thousands of limbs get set aside, get over-manufactured, and accumulate in clinics in people's closets, even though they retain years and years of use to them. And they simply cannot be reused in the United States due to the way that they are classified as medical devices and a mountain of regulations for which the United States is known for. So in short, pentamedical recycling, we bridge the gap between this valuable supply and the tremendous need for it all over the world. How do we do that? Our operation is split into 3 major phases: the collection of that supply, the preparation of it, and the dispatching of it all over the world. So first, we work to collect it from individuals, from people who are users of prosthetic equipment and accumulate 1, 2, 3, 4, 5 legs in their closets. Clinics who, in the fitting process throughout the year, they accumulate the extra feet, the extra liners, the extra knees, and don't really know what to do with it because, again, they cannot reuse it in the United States. And manufacturers who tend to accumulate last year's model and won't be selling it in this year or next year. And so they are known for quite literally putting it through industrial shredders and getting rid of it, which to me is terrible. Finally, we collect all of that in our warehouse where we sort all of it, we clean it, we prepare it, and we actually inventory each and every item, putting it into a database which we make available to our global partners. That way, our partners can actually go through the list of what we have available and request exactly what they need. Once we receive a request, we package it up and send it out. Our partners range from large public-private hospitals, smaller prosthetic and orthotic clinics, and even schools of prosthetic and orthotic sciences, wherein we actually ship out components for training purposes so that we can empower future prosthetic and orthotic professionals in their educational programs. And of course, global health nonprofits as well. While that model might seem quite simple at a glance, it's just collecting, preparing, and redistributing, it actually requires a great deal of care, responsibility, person power, and time. Here on the left, you see a table filled with metallic components. It's a photo that depicts very small components, larger components. These are all the pieces that make up a prosthetic limb. We deal with the small building blocks of the prosthetics. When we receive donations of prosthetic goods, if we get a leg, we don't just rebox the leg and send it across the ocean. We actually break it down into the usable pieces so that when we send it to a clinic on the other side of the world, that prosthetist is able to rebuild a custom leg for the patient sitting right in front of them. And of course, making sure that each piece is in good quality, is clean, takes a great deal of time and effort. On the right-hand side, you see a volunteer actually preparing to take apart a full prosthetic limb. Again, this is the disassembly of the limb so that we can extract the still usable pieces, the knee, the foot, the pylon, all the pieces that we will then very carefully add to our inventory. I want to note that a lot of the equipment that we get, again, is in a very good condition and in many cases, still in the packaging. We get a lot of equipment that is brand new, donated to us by clinics and manufacturers. I also want to bring your attention to the small little labels that are on all of the components. This is a system that we custom created so that each item gets an item ID. That item ID is put into our database, and in it is included a lot of data, including model number, size, length, skin tone even, so that our partners are able to request exactly what they need that is appropriate for their patients' activity levels, even for their environments. Once we receive a request, we pack it up and send it out to our partners. Sometimes we send a few boxes at a time, sometimes we send whole pallets, but we have now sent out equipment to 30+ countries all over the world. Our partners range in size, again, from small rural clinics all the way up to larger hospitals that have entire prosthetic and orthotic departments. But it is our partners that are really core and integral to our work because they are the ones who are actually fitting the patients. We are not able to do that from our warehouse in Westchester. We are simply empowering them to continue supporting their communities with this extremely valuable resource. So we really couldn't do our work without our partners. And on that note, also, that list of partners is growing, is ever growing. We consistently get phone calls, emails, Instagram messages, you name it, we get it, requesting for partnership with us, which again speaks to the incredible need for this valuable equipment. To date, we have shipped out over 14,000 components. Just in 2025, we sent out over 4,000 components. It takes approximately 5 major components to make one full limb, give or take. And so we've sent out the equivalent of 840 limbs in 2025. And our goal for 2026 is to send out 5,000 components, the equivalent of 1,000 full limbs. Those are just the numbers. We know that real impact is the way that lives have meaningfully changed. We always say that physical mobility means so much more than just walking. It means being able to go back to work, being able to go back to school, being welcomed back into the community. In many instances, there's a lot of stigma associated with disability. It also means, in the case of little Diego, in the case of little Diego here on the left, a young boy standing on a soccer pitch, being able to pursue a hobby and being able to be a kid. And there's really no price you can really put on that, reclaiming a childhood. These are the real photos and real stories of our beneficiaries. And like I said, we want to continue helping so many more. These are more photos of our beneficiaries, and we want, 1,000 times more than just this. Thank you so much for listening to me speak about pentamedical recycling, and we hope to do so much more in the future.
Thank you. Thank you, Anna. That's a very interesting model as well, recycling. So thank you for that. I suppose the audience has questions, so I'm happy to open the floor for anyone who wants to come in, to any one of the speakers. Yes, the lady there in the back.
Hello, my name is Fabiola. I work at Earth Medicine, which is a non-for-profit organization based in Lesbos who provide physical rehabilitation services to people, displaced people on humanitarian crisis. My question is to Mr. Mohammed. I'm very interested. Most of our patients presented with amputations due to injuries at countries at war. And we are facing enormous challenges to get prosthetic limb for those patients. My question is, how is it possible to get a prosthetic limb without the patient being present? I mean, does it need the person to be present to be measured? How does it work? This is one of the big challenges we are facing at the moment.
Okay, thank you so much for the question. So I guess most of the prosthetic companies now are heading to the digital era, so including us, and we are working so hard on that. So we fitted multiple patients without meeting them personally or by traveling to them. So we had multiple patients from Libya, so they didn't come to Tunisia. They were children, they needed to come with parents, so it was very costly for them, even more than the prosthetic itself. So sometimes we send an engineer, sometimes we tell them just to 3D scan it. Depends from a case to another. Some cases, especially for the lower limb, are a bit, sensitive, depending on how they lost their limb, if they have diabetes or not. You see, there are a lot of specifications that you will need a prosthetic specialist on the field so they can give us the right details. But we can still, based on all of that, if we get reliable data, we can still customize solutions. We can still reduce the cost of these solutions, and we can still implement, because we are going toward implementing or franchising the cure care centers that we are having that doesn't require much of investment, initial investment. So a couple of 3D printers, 3D scanners, even with iPhones, iPhone 11 is the minimum, and you can start making prosthetics locally with the know-how decentralized. So yeah, we can talk about that.
Thank you. Mohammed? Anyone else? Yes?
Hi, my name's Kirsten. I work with Light for the World. It's an NGO. My questions are for Anna. The first is, when you're working with prosthetic workshops in sub-Saharan Africa that might use different design and production methods, does Penta provide training on how to create prosthetics using parts from the US? And do they provide info or training on maintenance? The reason I'm asking this is a lot of times the equipment that we see provided to our partners ends up in what I can only describe as a graveyard. And then in the case of children who outgrow their devices, does Penta work with the recipient partners as well to continue the recycling process? Thank you.
These are great questions. The first one is, so there are a couple of prosthetic fitting models that exist. We work with the modular components, and before we even think about sending them over to any partner, we have a number of phone calls and assessments to determine if they are trained and familiar with this particular model. There are other models like the Jaipur foot model, the ICRC model, which doesn't work with this particular modular component, like fitting together of components. So before we even send boxes, there are a number of conversations that are happening. We send to clinics that know how to use these particular pieces so that they don't end up in a graveyard. That is the complete opposite thing that we want to happen. We send to individuals and workshops that have the ability to make a socket, because that's one thing that we're not able to do from our warehouse in Westchester, New York. So we have to go through a vetting process before we even partner with a workshop anywhere in the world, not just in sub-Saharan Africa, to ensure that not only can they make a socket, but they're able to integrate these components and this technology into that socket. Overwhelmingly, this is becoming the standard. There are still many places that are using the ICRC technology and the Jaipur foot. However, overwhelmingly, many, many workshops around the world are using this modular technology. Your second question, children. Yes, so we encourage the redistribution of the components in the same way that we are receiving prosthetic legs from children in the United States. Like, we get boxes full of them, and we line them up and you see the growth, right? So we add those components to our inventory, and when we are communicating with our partners, in the spirit of redistribution, we ask that if a child in, say, Kenya is receiving a prosthetic and they outgrow it in a year or two, that they return it to the clinic so that it can be reused. We push for that as much as we can. Yeah, that's as much as we can do at this point.
Thank you, Anna. Can I add a question to that? Because
Yes.
I really like the way you described it, and also it seems very much a process with quality indicators where you monitor actually what you're doing, et cetera, et cetera. So what would you reckon are the most critical factors that you still feel that you should improve in order to make all the recycling process successful?
I would say our biggest barriers right now are, overall, globally, the prosthetics world, there's simply not enough prosthetists to fit the need. So when we work with a clinic, we don't want to overburden them with more work. We actually just want to empower them with additional equipment and make sure they're able to serve as many people as they can. We want to get as much information back as we can. Of course, any nonprofit relies on feedback and data and impact reporting without overburdening these already overstretched prosthetists who are serving, so many people. So we as a nonprofit are always improving, like how to best improve our data collection without making it prohibitive to the prosthetist. Secondly, we are always trying to improve the shipping process. International shipping is a beast, and at our core, we are a bit of a logistics company. We are constantly shipping, exporting items, and so I would say that continues to be an area that we want to improve on.
And the fact that these components are not recycled in the United States,
Yeah.
that is due to legislation, you said?
It is. There's no real channel for giving it to the next person in the US. So if I was a prosthetic user and I had, a $10,000 knee and I used it for 1 week and realized, this isn't the right knee for me, I can't return it to the company. I can't give it to my friend who's an amputee. It literally retains no more value, but we know the value. There's a ton of value to it, a life-changing value. So there is this weird gray market where if you go onto eBay, you can find Otto-Bach knees or Oster knees, but eBay actively pulls those listing downs because you're not supposed to be selling that kind of stuff on eBay. So, and people ask us all the time, they're like, oh, we donated this leg to you, can we get a tax write-off? And we're physically unable to provide a value even to the donor. We can acknowledge the donation as, thank you for donating your leg. We got the Otto-Bach knee, an Otto-Bach foot, an STNG pylon, and make a list of the components that we got from that leg, but we are unable to list a value because technically once it's been used by one person and donated to an organization like ours, it is deemed unusable, and clinics actively tell their patients to throw it out.
Clear.
So we are one of the few organizations that are trying to fix that problem because we know how life-changing it can be.
Thank you. More questions? Then I have a question for Enzo. Enzo, you very nicely described what you're doing in Peru, and it seems like it's not only development but also production of prosthetics. And my question is the market in Peru big enough to make such an industry, let's say, sustainable, or are you also looking to other markets, maybe in South America?
Yes. So regarding the number of people with upper limb amputations in Peru, the estimation is about 25,000, but that belongs only to official records. As I told you all around the table, the numbers, when there's a really big informal market like ours, can be a really black hole, right? So yes, we have enough market in Peru, but of course, this problematic that I described repeats on itself in all the countries that are in the region. We have a lot of informality, we have a lot of cases that are a result of injuries because of labor, and right now we are working with our neighbor countries. One is Ecuador in the north and Bolivia in the south. We're looking for a complete integration of the continent with this solution that we only need to have a person inside on that country to develop the 3D scan. Those files can be sent back to us in our headquarters in Lima. We get to design the customization of the prosthesis, no matter the complexity of it. And once those files are ready again, they can be sent back to the local place to be produced locally.
Okay.
Yeah.
Okay, clear. Thank you. And Mohammed, on one of your slides, I saw a map with North Africa, Europe, and the Middle East. I suppose you're almost ready to step into those markets as well. What are the main barriers you think for entering, for example, a demanding market like the European Union?
Yes, that's a good question. I guess the main barriers is into areas, financial and the channels. It's, you know, like in this world, having the right product doesn't mean that you'll be succeeding or that you're making a change. We see a lot of amazing things happening, but they're stopped somehow on the way. So we've been doing this very organically, so with zero investment, so it was very slow but very sustainable. So today, whenever we go to a new market, we try to do our best to put our legs there and to make a great job and then to make that part autonomous. So our first thing we did is getting the CE certification. So our product as our European, accepted in Europe, I guess in most of the world except the US. Now we're working toward the FDA also. I guess the regulatory work took almost 2 years from our life. We couldn't sell without that. So it was too much for us because we were not located in Europe. We had to go through a mandate, and I guess these are like the main barriers. So I guess regulatory changes from a country to another, even if you have the CE, you still need to adapt with local regulatory framework. So the non-unified framework is a problem, but we are working hard to solving that. Financially also, I guess that's another problem. And third point, as I explained, the channels. I guess we need a lot of lobbying, a lot of support, a lot of channels to make startups get and innovative products like Bionics and like the amazing work happening here, get the channels to take that to the right people. So yeah, these are like the main things.
Those are the main, okay. Good. Any more questions? We're going towards the end of the session, but there is still some time. Yes, please.
Hi, Kerry Johnson from AT Scale. I'm fascinated by the Penta recycling, and you've just got me thinking about two questions which are linked, which is, have you managed to secure any kind of agreement with the manufacturers that they could already inform their customers about Penta when they receive and have their leg fitted? Because I guess there's many, I mean, you're collecting a lot, but there must be many, many more that are still thrown away or in people's wardrobes or under their beds or whatever. And then second, on the flip side, I suppose, like, it sounds like you have a lot of demand, but what work do you do to inform clinics in these countries that you exist, or is it just currently word of mouth?
Great questions, thank you. So on the information, the first question, the point at which a patient is fit in the clinic, that is I would say the touch point that a patient would need to be informed, hey, when you are done using this prosthetic in a year, 2, 3, there's an organization that exists that you can donate to. It's not so much the manufacturers, it's the healthcare providers, it's the prosthetists, it's the clinics. And we've done really, really great work on getting in front of as many clinics as we can in the United States. We've even gotten in front of Hanger Clinic, which is the largest provider of prosthetic care in the entirety of the United States. They have 1,000 locations around the US, and to collect 1,000 locations worth of excess componentry, I mean, that's a lot. We're at the point where we want to collect more across that network, but we are such a small organization, we simply cannot. So we are actively fundraising to increase our capacity to collect from all 1,000 locations, but we are slowly getting there. But I will say, when we do encounter the occasional small private clinic and we say, hey, we exist as a nonprofit, we can be a resource for your patient, there is always a sigh of relief. They're always like, oh my goodness, we've been waiting for a channel through which to send this equipment, because the prosthetists know how valuable it is, how expensive it is to patients, and to throw it out and discard it is really quite a shame. On your second question, we have not had to actively advertise our services for a very long time. As I may have mentioned, we have now almost like a waiting list for where we might consider expanding to next, and we have like an interested partner survey where when we do get a communication via email, call, Instagram message, Facebook message, from any channel. We send them the survey, and we have to understand a couple of things. Do they have the socket making capability? What kind of level of technology are they using? Are they using the ICRC technology, the Jaipur foot, or the modular technology that we are able to supply the equipment for? There's a number of questions we have to ask, a number of phone calls, a number of communications, assessments we would have to undertake in order to even bring that clinic on. That said, we are working on growing deeper in the countries we already are before expanding to new countries. It's always easier to ship one big pallet or two to one location and then expand out instead of sending like a couple of boxes to one country, 2, 3, 4. So we have a long waiting list. Again, it speaks to the need and the demand for this equipment. And yeah, I mean, we hope to continue growing as an organization to fulfilling as much of that need as we can.
Thank you, Anna. Okay, we're coming to the end of the session. I would like to thank our speakers. I think we've listened to 3 examples of highly committed organizations, individuals that are here, that came all the way to Vienna to talk us about their experience. So thank you very much for that, and I wish you really a lot of success in your activities. And thank you for being here today and to listening to this session, and enjoy the rest of the conference. Thank you.
Thank you.
Thank you. It was a pleasure.